Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent funding from Novartis.
This program is presented by Medscape Education Global.
Hello everybody, my name is Kaushik Ray. I'm President of the European Atherosclerosis Society, a Professor of Public Health and a Consultant Cardiologist at Imperial College in London. Welcome to this program entitled A Deep Dive into Long-Term Efficacy and Safety of LDL Cholesterol Lowering, Modern Strategies for ASCVD. Now, joining me today are a couple of good friends. Scott Wright, who's Professor of Medicine and Cardiology at the Mayo Clinic from Rochester, Minnesota, and Alberto Zambon, who's Professor of Medicine at the University of Padua in Italy. Welcome, Scott and Alberto. Hello.
Hello.
Hello, great to be on board.
Well, I'm glad you're both here because we've actually now got quite a lot in the way of lipid-lowering therapies, and there are a lot of choices for doctors to make. But before we go into some of the treatments that are available, the why and how, let's maybe start with a case study just to set the scene for our audience. So I'm going to start by discussing a 57-year-old male patient with a BMI of 32, so a little bit overweight. He presents with a myocardial infarction, has the usual procedures. A stent is placed in the LAD. There's no flow-limiting disease in other territory, but interestingly, he's got a past history of a stent in the right coronary artery for stable anginal symptoms 5 years earlier, so at the age of 52. Now, he's been on atorvastatin 20 milligrams, with LDL's 2.6 or 100 milligrams per deciliter. He has the usual gamut of medications, dual antiplatelet therapy, at that time at least a beta blocker, an ACE inhibitor. His blood pressure is reasonably well controlled at 128/82. So he's obviously got progression of disease despite an LDL of 2.6. So we switched to rosuvastatin 40 milligrams, and the LDL does improve somewhat, comes down to 2.0 millimoles, so 79 mg per deciliter. Trigs are not particularly elevated, 1.2 millimoles or 106 mg per deciliter. And the HDL is 1.2 millimoles, so 46 milligrams per deciliter. If we think about other residual factors, we might think about renal function, as the eGFR is normal. His hsCRP is not particularly elevated, it's under 2. His lipoprotein A, we should be testing for that. That's only 25 nanomoles per liter. And his HbA1c, if you like, puts him in the pre-diabetes category at 5.7 rather. So if we're thinking about biological approaches, so we obviously start with diet, lifestyle, but all bets are kind of off here in somebody that's got coronary artery disease. And when we try to think about what else needs to be done, we can probably think about residual risk in a number of ways. We can think about residual cholesterol-related risk, residual inflammatory risk, residual thrombotic risk. Residual risk may be related to triglycerides and triglyceride-rich lipoproteins, lipoprotein A, or from diabetes. And we've looked at all of those in this case. So maybe I could turn to you, Scott, and you've got this clinical picture. What would the US guidelines recommend that we do next in this particular individual?
Kosh, I think this patient would be classified as very high risk. The current U.S. guidelines are undergoing revision, but we have a consensus statement, an expert consensus statement from 2022 that subdivides patients like this into high risk and very high risk categories. He's had a recent myocardial infarction. He's had a prior history of PCI and angina, so very clearly established atherosclerotic cardiovascular disease. He's got elevated lipids despite being on a statin. Fortunately, he doesn't have diabetes or elevated blood pressure. but he would be considered very high risk. So our current recommended thresholds for treating his LDL would be to reduce it by at least 50% and to get it down to an LDL of 55 milligrams per deciliter or lower. And to bring his non-HDL cholesterol down at least to below 80 or 85 milligrams per deciliter. And this patient will likely take at least 2 medications. He's been up-titrated to rosuvastatin 40. His LDL fell from roughly 100 or so down to 79, which is a good drop. But he needs to go down an additional 30 to 40% to get below 55 milligrams per deciliter. So he's going to need another therapy. And the current consensus statement would recommend either an oral medication like ezetimibe or bempedoic acid, or a PCSK9 therapy such as a monoclonal antibody with alirocumab or evolocumab, or a small interfering RNA agent such as inclisiran. So that's what we currently recommend in the U.S. It's based upon some, I think, elegant clinical trial data in the last 5 years. And I think it's a really good recommendation now from our consensus statement.
So, Scott, thank you so much for going through that, because, I mean, the key take home is actually we're moving away from monotherapy to combination therapy, aren't we? And that's really a key thing there. So, Alberto, maybe if I can come to you. So do the European guidelines differ in terms of their recommendations? What do they say about the management of a patient such as this?
I would say they overall agree with the US guidelines, what Scott said. The European guidelines suggest, as the US guidelines, to characterize the cardiovascular risk of these patients. Let me spend a word, because as Scott said, it's relatively easy because he presents with an acute MI, but he also has a history of previous PCI and stenting at age 52. Now, age 52, having a severe cardiovascular disease, characterize these patients as having premature coronary heart disease, which rings a bell because we don't have information about his family history, but I would be keen on knowing whether other relatives on his father's side or mother's side did suffer from premature coronary heart disease, because looking at the LDL cholesterol levels on 40 milligram of rosuvastatin, which brings probably a baseline LDL cholesterol, we look in milligram in the 170, 160 range, we may very well be facing a guy with the familial form of dyslipidemia, particularly hypercholesterolemia. Now, on top of that, the guy has a BMI of 32, which characterizes him as having obesity, pre-diabetes. As Scott said, it's a very high cardiovascular risk. I do agree. I would be even more, I would say, pessimistic. The guy is probably on extremely high cardiovascular risk. The guidelines in Europe suggest to have a multifactorial approach, and of course his blood pressure is probably well taken care. He has a dual antiplatelet therapy. Where we fail, as Scott pointed out, is in controlling properly the LDL cholesterol. After the first PCI, he got a TORVA-20. A TORVA-20 is not really an approach that provides you what the guidelines suggest. The guidelines in this case suggest at least a 50% cholesterol reduction from baseline and reaching a goal of LDL cholesterol 55 or 1.4 millimolar or less. So clearly we failed at the very beginning. I don't know when he switched to Rosuva 40, but as you pointed out, even with Rosuva 40, the LDL goal is not achieved. So we are playing with these patients at extremely high cardiovascular risk for 5 years without properly controlling his lipids. That's the key point.
Alberto, so the European guidelines talk about now further add-on therapies. Which ones, how do they work, and what order do we think about them?
Well, as you mentioned, the guidelines suggest a stepwise approach. They suggest in these patients at the very high cardiovascular risk to start with the maximal tolerated high-intensity statin therapy. Again, 20 atorvastatin was not the case. 40 Rosuva is the case, clearly not reaching the goal. As step number 2, they suggest to add, as an add-on therapy, ezetimibe, an oral agent that inhibits absorption of cholesterol, and eventually as a third-line bempedoic acid. This is called stepwise approach. I think if you allow me to go back just for a couple of seconds and look at the recent history of these patients from the first PCI on, is clearly an example of a real-life cardiovascular risk, poor management. Because the stepwise approach was not applied. He started being undertreated. He did not. He moved to a high-intensity statin. But even with the Arzuva 40 is not a goal. Combination therapy was not implemented, which is the step number 2. So I think we're really having in front of us an example of how the poor management of cardiovascular diseases and risk factors happens. The other actually consideration, he's on Arzuva 40 and his LDL cholesterol is 2 millimoles or 80 milligram per deciliter. I doubt that by adding at this point, 5 years later, combination with ezetimibe or bempedoic acid will bring him down to goal 55 or 1.4 or less. So these patients, considering all the comorbidities, the premature coronary disease, likely the history, family history of familial dyslipidemia, is probably a good candidate to use injectable therapy. As you mentioned and Scott mentioned, could be monoclonal antibodies directing against PCSK9, which basically binds circulating PCSK9. PCSK9 is a protein that affects and modulates LDL receptor life cycle. If you block PCSK9 in the blood with evolocumab or alirocumab, you allow maximum recycling of the LDL receptor on the surface of the hepatocyte, allowing the liver to take up as much LDL as it can. So average LDL cholesterol on top of background therapy is about 60-65%, which of course would be ideal in this case, to lower cholesterol well below the goal of 55 milligram or 1.4 millimoles. The alternative is a small interfering RNA, a technique of gene silencing where you use a double-strand RNA inside targeted to the liver. So it's not going anywhere. In inclisiran, for example, it's injected in a very small dose. It disappears very quickly because it binds to the surface of the hepatocyte. And inside the hepatocyte, the cells in the cytoplasm prevents PCSK9 from being synthesized and produced. So it's not blocking PCSK9 in the blood, but is actually silencing the gene and blocking production of PCSK9 from the liver. Effect on the LDL cholesterol is about 50%. Both monoclonal antibodies are and inclisiran are injectable. Very convenient dose regimen. It's by far the most common with monoclonal antibodies is twice a month, so 1 sub-Q injections every 2 weeks. With inclisiran, after a booster, after 3 months of the first injection, then it's twice a year. It's 1 sub-Q injection every 6 months. Very convenient. And then if later on we'll talk about adherence, that's a major plus.
Very good. So you mentioned injectable therapies. Scott, so we've had oral medications. Statins have been around since around about 1990, and we've got a lot of safety data. Injectable therapies, monoclonals the last decade, more recently inclisiran over the last 3 years or so. What do we know about the long-term efficacy and the safety of these modern injectable therapies?
Kosh, the modern injectable therapies have an excellent safety record. In fact, they probably have fewer side effects than even statins, which have minimal side effects. The Odyssey outcomes and the Fourier open label extension studies looked at both alirocumab and evolocumab and showed really no significant side effects. There are no muscle concerns, no hepatic issue concerns, no kidney issues or diabetes issues. Both of these injectable monoclonal antibodies really potently lower LDL cholesterol by 50 to 60%. You can see a best case scenario with about a 60% reduction with either of those, and typical reduction is 50 to 55% in my practice. What's really interesting about the open label extension with the Fourier trial is that patients who were initially on placebo in the randomized controlled portion of Fourier and then switched to open label evolocumab, there was actually a legacy effect for those initially assigned evolocumab, continued on it versus placebo to evolocumab. So that really durable and potent lowering and frequent use of the monoclonal had an extended benefit and no safety concerns. Injection site reactions with the monoclonals are 3 to 4%. Drug-drug interactions are really minimal. Neutralizing antibodies are really minimal. And these are excellent drugs, an excellent safety record, and excellent secondary prevention outcome data. We've also looked and examined, Kosh, as you well know from being a collaborator and co-author with inclisiran. And really, it is quite, as Alberto said, it's quite a very potent LDL lowering drug. On average, about 50 to 55% reduction over 18 months in the phase 3 treatment trials. And in the open label extensions, including FH patients, ASCVD patients, and patients with risk equivalents, had about a 50% LDL reduction. Again, the safety with inclisiran was quite good. There was really no safety signal of any concern, no issue with developing type 2 diabetes, no issue with liver injury, no issue with kidney injury, and certainly no issue with any muscle injury at all. So I think we're really in a good spot today with all of our PCSK9 therapies, the two monoclonals and the small interfering RNA inclisiran, and that all are durable in terms of being good, being tolerable for the long run. All are potent at reducing LDL on top of maximally tolerated statins by at least 50%. And none of them have any safety concerns or side effects that would even mimic what statins do with myalgias and things of that nature. I think it's also really worth pointing out the big differences really between the monoclonals and inclisiran are the monoclonals likely have a slightly more LDL lowering efficacy than inclisiran. You can get up to 60%, while with inclisiran, 55%, 56% seems to be the max typically. But on the other hand, inclisiran is given twice a year on average. As Alberto said, you get a booster dose on day 90 after the first injection, and then it's every 6 months after that for as long as your patient is on the therapy. Whereas with the monoclonals, almost everyone is giving them every 2 weeks now. So the other issue, at least in the European and US markets, is that the patients will self-inject the monoclonals at home, but with inclisiran has to be administered by a healthcare provider. In the US, we're doing it either through physician offices or through infusion centers. But we have really good data with these drugs, and I think we can be reassured that they are safe as well as effective. Now, Kosh, if I could turn to you and ask, what data is yet to come? Where are the gaps? Where are the unmet needs? And where do you see the horizon in the next 5 years?
No, thanks, Scott. So I think with all lipid-lowering therapies, because we've now got at least 5 different ways of lowering LDL, which in randomized controlled trials will translate into reductions in cardiovascular events. The LDL part is pretty much well established as a causal pathway for reducing atherosclerotic cardiovascular disease. And so with all trials of all therapies, we start with LDL lowering, and the bit that we don't have at the moment yet, but which is ongoing, are the cardiovascular outcome trials. So for inclisiran, there's a very large cardiovascular outcome trials in the US and the UK called Orion 4. It's event driven, so 15,000 patients, around about 5 years of follow-up, people with established cardiovascular disease. And one of the things that we know, for example, in some of the monoclonal trials is that the duration of treatment was relatively short. In the first year of treatment, you get about half the benefit in relative terms, which increases in years 2, 3, and 4. So that will be important. There's also a second global cardiovascular outcome trial with inclisiran looking at people with elevated LDL cholesterol despite statin therapy, again, in people with established cardiovascular disease, the typical 3-point MACE outcome. There's a primary prevention trial also called Victorian 1P that's being done. And we shouldn't forget that there's a trial called Vesalius CV, which is using evolocumab in people with coronary artery disease, but no acute manifestation. So, for example, no prior history of MI, no prior history of stroke. So it's a little bit similar to the ticagrelor study called Themis in people with stable disease. So it's not pure primary prevention, if you will. There's evidence of atherosclerosis, and that will actually give us that, again, that further evidence that combination therapy and lowering LDL cholesterol by any means translates into reduction in clinical events. So I think that's what we can hope for. Alberto, maybe I can just turn to you. So we talk a lot about current treatments, and we're talking about adding in a second treatment to achieve cholesterol goals on a background of other therapies. What are the limitations of current or previous approaches? I'm thinking particularly in terms of adherence, for example, and how might some of these modern approaches overcome that? Is adherence relevant?
Adherence is key. It's not relevant, actually. In fact, it's most of the recent papers looking at the effect of lipid-lowering therapy on cardiovascular events takes into account intensity of the lipid-lowering approach as well as adherence. In fact, some of the recent observations suggest that optimal adherence to lipid-lowering therapy, even or regardless of the treatment intensity, is associated with cardiovascular benefit. In fact, I think a paper you are co-author with Kamlesh Kunti, actually, looking at a clinical private practice or primary care was clinical setting in the UK, looked at adherence and intensity of treatment, and the clear results of that paper was amazing, actually, because they showed that having good adherence with low intensity is associated with greater benefit than having a very high intensity therapy taken with the very actually poor adherence. So adherence plays an amazing role. Of course, the best results are a combination. That's the key point. A combination of highly effective lipid-lowering approach, we're talking about injectable, as well as good adherence. So the two measurements are combined together. I think in that paper you proved that looking at these patients with cardiovascular disease or at a very high risk of disease, the actual combination of adherence and intensity you observed in real life led to an event rate of about 72 events per 1,000 persons per year. Whereas if we optimize, that's an hypothetical result, but if we optimize adherence with intensity, so high intensity with optimal adherence, that number probably was going to be slightly lower than 50. If I remember correctly, 48 events per 1,000. Now, let's apply it very easily to 500,000 people. That translates into 12,000 events prevented per year. It's an amazing number, actually, clinically speaking. Also, with the new injectable, we have to deal with the challenge to achieve chronic, durable, sustained LDL cholesterol reduction. You know, with statins as well as ezetimibe, bempedoic acid, we have actually a variability associated with the response. It's the classic, waterfall actually response chart that we see. And every standard deviation of LDL above the average reduction is associated with a significant number of cardiovascular events, whether it's stroke, any events, acute MI. So it's basically the concept of cholesterol burden on the flip side of the coin. So we are used to teach our colleagues that the atherosclerotic disease depends on the burden of cholesterol that our arteries sees over time. It's not the peak of the cholesterol, it's how much cholesterol my artery sees today, tomorrow, next month, in the next few years. So it's level of cholesterol multiplied by time. So the benefits, of course, respond to the same criteria. It's how low we achieve or how effectively we lower cholesterol for how long we keep that cholesterol low. So that's why adherence is crucial. And actually, medication burden is really associated with the degree of adherence. A more complex medication burden, let me take an example, statin therapy, it's 365 pills a year. Actually, is associated with a much worse adherence than, for example, injectable PCSK9 monoclonal antibodies, 26 injections. Even less, of course, or even better adherence with the PCSK9 small interfering RNA, such an inclusion, only twice a year injection. Not only and the injection is provided by healthcare professionals under their supervision, optimizing adherence even more. I don't know in the US, but in Italy, for example, nurses, doctors, soon pharmacists actually will be in charge of administering inclusion every 6 months, whereas monoclonal antibodies can be self-administered by the patients. Last but not least, the durable effect on LDL cholesterol is associated with inclisiran. Between injection in that 6 month period of time, you have a low stable LDL cholesterol, which once again, it's very relevant if you count that the benefits are cholesterol exposure, so lower level multiplied by number of days at which that level remains low. Just to finish, 2 real life data coming from monoclonal antibodies. One, it's coming from the Heyman study, evolocumab in a number of European countries, real life situation, not actually randomized trial, adherence 92 to 93%. Amazingly high if we look at the adherence we usually have on statin therapy. Italian data coming from a small study, about 800 people, real life data, once again, adherence of about 95%. These monoclonal antibodies, we're expecting an even greater adherence with inclusion. So the problem is effective therapy, good adherence. I think that the requirements are both fulfilled with the combination therapy that includes injectable and particularly small interfering RNA.
Well, that's a very clear message actually for our audience in terms of what the added value is really of these injectable therapies, both in terms of potency and the frequency of dosing. So it's fairly close to the to finishing time now. So perhaps I can just turn initially to Scott and then to Alberto. And so Scott, reaching the end of our discussion, what are the key takeaways for implementation of these modern strategies in clinical practice? You talked a little bit about the US model. So perhaps just maybe delve into that and in a little bit more detail and summarize for our audience.
Very good, Coach. As Alberto and you have also said, that it's really important to risk stratify the patient and to treat them to the appropriately low LDL threshold or target. Too often we are missing those targets and thresholds because we are not recognizing the higher degree of risk that our patients have. And as Alberto pointed out earlier, the gentleman that was the case example was not well managed for the 2-year intercurrent interval, and that likely contributed to his recurrent myocardial infarction. I think to get patients to the lower LDL goals and thresholds that we now see recommended, we're going to need to be using combination therapy. Sometimes that will be 3 agents, including a statin, another oral agent like ezetimibe, or bempedoic acid, and then a PCSK9-directed therapy. So we need to really bring the LDLs down in the very high-risk patients to at least 55 milligrams per deciliter, but it's certainly okay to take them lower. I have no concerns in my practice of taking LDLs for the very high-risk patients down into the 20, 30, or 40 milligram per deciliter range. And there are data now from the 4EA trial showing that's very safe to do. Alberto made an elegant argument, and I completely concur that adherence is as important as the degree of LDL reduction. If we don't keep patients on the medications, and if we don't see the LDL consistently staying lower, they do face additional risks that we're not even often aware of. It's impressive, the European adherence data between the monoclonals and inclisiran. In the US, we do not see that degree of adherence to monoclonals. A recent presentation at the American Heart Association showed about a 60 to 65% adherence rate with the monoclonal antibodies and a 75 to 80% adherence rate with inclisiran. So the twice yearly injectable seems to have a much higher adherence rate in the US market than the monoclonals. We do require in the US market that the inclisiran in particular be injected by either a physician or nurse. We have not turned that over to pharmacists yet. There's no indication that it may move in that direction. So it will either be in your office through you or your nurse, or at an infusion center where a physician order is being implemented by a nurse who's licensed and trained. I think all of the PCSK9 agents have benefits. I think inclisiran has some unique benefits, being less often given, higher adherence, very good safety profile. The monoclonals equally have a very good safety profile. Both are superior to any oral or combination of oral therapy with regard to lowering LDL. So I think the takeaway today, if I could just leave one thought, it's take them low and keep them low and keep them adherent to their medications. Thank you.
Thanks, Scott. So very good. So Alberto, same question. Your key takeaways for clinical practice?
I do agree with Scott's messages. I think the cardiovascular approach, cardiovascular risk reduction approach in our patients, particularly at very high or extremely high cardiovascular risk, should be multifactorial. But focusing on LDL cholesterol lowering, the approach should be started as early as possible. Our patient's history is an example. It should have started at least 5 years earlier. And that comes to the second point, highly effective and safe. He missed 5 years with clear under treatment. So combination therapy now should be the new basic standard of care. We should move away from that statin monotherapy. Clearly, the large majority of patients at high and very high risk cannot achieve that 50% cholesterol reduction with statin monotherapy. So combination statin ezetimibe or combination triple therapy for those at extremely high risk where it's allowed, including injectable PCSK9 inhibitor, should be used upfront as a first line strategy. Of course, adherence is a key issue. So that should be implemented by using, for example, for oral therapy, fixed dose combination whenever it's available with rosuvastatin, ezetimibe, atorvastatin, ezetimibe, for example. The use of injectable provides a greater benefit, particularly increasing for that simple dose regimen and the durable effect on LDL cholesterol. So I think now we have the tool. It's really up to us to implement the actually cholesterol, LDL cholesterol lowering, making it simple, easy to implement in the real life. But we do have the tool now. So it will be only our fault if we cannot succeed.
That's very well put. So I'm just going to close up and just briefly summarize. So essentially, we always start with assessment of clinical risk that guides the intensity of treatment for those at highest risk. So particularly if you have atherosclerotic cardiovascular disease at an early age and you have progressive disease, then these are people whose risk factors are not adequately controlled. So in those people, we need to think about combination therapies. I mean, statins alone, it's not just about goal. The end game is to reduce cardiovascular risk. If you like, the journey in part is through further LDL lowering, and the journey in part is through the use of combination therapy and also patient adherence. So we've got good data now that a lot of these modern therapies, the injectable therapies, are both safe and effective, and there's no downside from achieving a lower LDL cholesterol other than reducing your probability of further disease in the future. So I want to thank my colleagues and the audience. Scott and Alberto, thank you for a great discussion. And thank you to everyone for participating in this activity. Now, please do continue to answer the questions that follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.